I try not to treat them because I'm not very sure. Our problem.
Yeah, it's big problem.
Yeah, the AGM. Let's finish our AGM.
Oh.
Yeah. Father is also now in the council. Father is now in the council.
Okay.
Yeah. Earlier also he was there, but I don't know how he got. Good evening, fellow members of the IMPA, colleagues of the medical profession, respected resource persons, ladies and gentlemen. I am speaking to you today because I have been elected the president of the IMPA again. We just finished our AGM and now I have taken over the. Thank you. Thank you very much. So before we start, we will have the national anthem, please. Thank you. Actually, due to the present corona and COVID restrictions, we are restricted to have only about 30 participants, and rest of the personnel can listen to this say medical update program by hybrid. Also, and also it will be uploaded when you want to watch the lecture again. It will be uploaded on our website. So I would take this opportunity to for you all to make use of our newly upgraded website, which is up to date. Before we proceed with the further, I would like to request you all for a 1 minute of silence because we have lost two past presidents in recent past. One is Dr. Ratnapala and Dr. Lakshman Veerasena, who passed away recently. So may I request you all to 1 minute of silence on their behalf. Thank you. Thank you. Thank you. Since we just finished our AGM, we have released our new journal for 2021, which is released and kept outside. You can have a copy of your journal for your reference. Now we will start our medical update program. First, our resource person is Dr. Nilesh Fernando Pulle, who is a consultant gastroenterologist and senior lecturer, University of Surgical Unit, University of Colombo, NHSL. Also, he's a MBBS, MD, FRCP, specialty is certified in gastroenterology from UK and is board certified in 2012. Previously, he was a consultant gastroenterologist at the teaching hospital Jaffna, and presently, and then before that, he was a consultant gastroenterologist at Adam Brooks Hospital, Cambridge. His special interests are interventional endoscopy, ERCP, EUS, and third space endoscopy. Words like POEM, EMR, and ESD. I think that will be Greek to everybody. And then IBD. IBD is inflammatory bowel disease. Okay. He has researched in 20 publications and 40 plus abstracts in local and international conferences, co-authored 2 books in gastroenterology. And I will now welcome him to make his presentation on a very important topic, NASH, NASH, and NAFLDL. Before that, I would like to introduce him a little further. His father is a council member, Dr. for pediatrician, senior pediatrician, Dr. Maxi Fernando Pulle, who's in the audience, and his mother is the famous lady, Dr. Rohini Fernando Pulle, who's involved, was very much involved with the IMPA in developing our Sri Lanka drug index. And he's the husband. His wife also gave us a lecture 1 month last at our RCME program. Her name is Tushari Matthew, but you will not know because she's still using her maiden name. And also his own brother is an orthopedic surgeon, doctor, right? Yeah. And also the wife's husband's brother's wife is also a hematologist. So the family of doctors. So we are in to have a very good presentation from Dr. Nilesh. Over to you, doctor.
Thank you, Dr. Asare. Thank you. I'd like to also thank the IMPA for inviting me to give this lecture. Yeah, it's indeed a privilege to the first time I'm having my father in the audience, giving a talk. Yeah. So what I thought was fat liver disease is a big, vast topic by itself. So I thought since I believe most of the audience and all the listeners will be primary care physicians who would be the heart and soul of medicine from a patient point of view. So I'll basically talk about this a practical approach of fatty liver disease rather than going into details about different aspects of it. because it's a big topic by itself and probably could be spoken for hours. Yeah. So this slide I just put to show the epidemiology, how bad fatty liver disease is what sort of a proportions it's in taken to the world. These red areas are the bad, worst affected areas, and you get the orange, yellow. So it's basically spread right throughout the world. So I mean, you would have known that fatty liver disease is any person who gets ultrasound scan, almost 1 in 3 people in Sri Lanka will have fatty liver disease. And the data, yeah. So basically, the global prevalence is about 25%. If you're obese, it's a bit more. It can go up to about 70 to 80%. And if you're diabetic, it's about 50 to 80%. Sri Lankan studies, which we did, also show that our diabetic population, patients who come to the clinic, if you do ultrasound scan, more than 50% of them have fatty liver disease in their ultrasound scans. There are other conditions which are associated with fatty liver disease, like sleep apnea, colorectal cancer, osteoporosis, psoriasis, and endocrine problems, and so on. So which I'll allude a little bit more during the lecture. So it's a big problem, as you know, and which has been recognized by the IMPA, and probably that's the reason why I was invited to give this lecture. There's been although this topic says NAFLD, there is going to be a change in the nomenclature, the name of this disease very soon, I think, and it's being debated whether it should be changed or not, because it's probably going to be called MAFLD, MAFLD, rather than NAFLD. So it's going to be called a metabolic associated fatty liver disease, to recognize what it actually means. It's a metabolic disease rather than saying non-alcoholic fatty liver disease, because they thought it was a NAFLD was a diagnosis of exclusion. Basically, we exclude alcoholic disease to say this patient has fatty liver disease. Whereas the MAFLD, basically, it's a diagnosis of inclusion. Basically, there are certain criteria, very similar to what you call the metabolic syndrome. I'm not going to detail about the criteria. The criteria I put down at the below the box. So it is basically the hyperlipidemia, hypertension, diabetes, all those criteria, the central obesity, so the waist, hip circumference, all those are included in like the metabolic syndrome. But basically the nomenclature is going to change, and very soon all the articles or whatever that you go to read would have the term MAFLD rather than NAFLD. Right. So I'll stick to the term NAFLD for the moment, just to avoid any confusion. So if you look at the classification of NAFLD, you get what you call the primary fatty liver disease, and they call the secondary diseases. Secondary diseases like alcohol can cause fat in the liver. There are certain conditions like hepatitis C, Wilson's disease, drugs like tamoxifen. There are certain, so lots of diseases, lots of entities can cause fatty deposition in the liver. Then you get the primary. So you don't get any secondary causes, you get the primary. In the primary, it's all divided into what you call simple steatosis, and the other entities, NAFLD, fatty liver with some sort of hepatitis, so what you call NASH. So there is some damage going on in the liver. And those are the people which we are worried about. So the NASH is again divided into different groups depending on the stage of the disease the patient is in, where you get early NASH, or you can get, there's some fibrosis going on in the liver. So you get NASH with some fibrosis. And of course, then stage of that fibrosis would be cirrhosis. And you can get even hepatocellular carcinoma with patients with fatty liver disease. So basically the classification is that, and it's very important for us to identify which the patient, if a patient comes to us, to identify which stage the patient is in, because the treatment, prognosis, lots of things, how serious we are going to talk about the patient, about the management depends on what stage the patient is going to be in this classification. Because NAFLD is again diagnosed with exclusion about alcohol, being obviously not taking alcohol. So the safe limits, again, there's an argument. Is alcohol safe for the liver? Is there any safe limit as such? But if you look at the literature, there is a safe limit of 7 units per week for women and 14 units for males. And so that's if you want to look at go by the previous classification. Yeah. So if you look at the natural history and the prognosis of fatty liver disease, so you get the fatty liver disease, and most of them, 70 to 90%, also about 80% of them would just have simple steatosis. They would not have any problems. Okay. So, but the 20% of people would go on to develop what you call that non-alcoholic steatohepatitis, or NASH, with some hepatitis, some damage going on in the liver due to the fatty liver disease. So 80% seem to have no problem. 20% would have some problem, and they would progress to advanced stages of this disease. And of those 20% who go on to develop NASH, another 20%, I'm just giving you so to make it easy, just 20 rather than giving a range, 20% would go on to develop cirrhosis. So when you talk to patients, you need to tell them, okay, 20% of you are going to have NASH, and 20% further are going to develop cirrhosis. And that's the population that we are worried about. And that's the population which is going to have trouble in the coming years, 10 to 15 years time. And this is a disease which will go a slowly progressive disease. Of course, there are rapidly progressive types also, but most of them would progress over 10 to 15 years time. So gist of it you should tell is 20% of you will have problems over the next 10 to 15 years. It's not something which is going to have problems over the next 2-3 months. That's very important when you advise patients. The other thing that we want to highlight is there is a possibility that even without generally the hepatocellular carcinomas come in cirrhotic livers. 95% of hepatocellular carcinomas come on a background of cirrhosis. But they have found that even with just non-alcoholic steatohepatitis, you can go on to develop liver cancers. So it's kind of in that sense also quite a serious illness, because we need to catch those. They can also present, just not develop cirrhosis, they can also have develop cancers in the liver. The other thing that we need to talk about when we talk about the patients is that fatty liver is a risk factor for cardiovascular diseases also. Even if you don't have any other problem, just the mere presence of fatty liver increases your risk to have cardiovascular diseases. So that's another point that we need to always stress when we talk about fatty liver to our patients. That's the HCC, about HCC. So basically, like I told you, the risk factor for HCC is about 2.26 if you have just a NASH only with some cirrhosis. If you're diabetic, if you're obese, if you have hypertension, if you smoke, obviously if you have a family history, the risk factors are much more if you have fatty liver to go on to develop hepatocellular carcinoma. Saying that, but still, I mean, if you are a cirrhotic patient, that's something again that probably if you are managing cirrhotic patients, make sure that you get an ultrasound scan done every 6 months to screen for liver cancers. That is done irrespective of patient symptoms. So any cirrhotic patients, make sure that you get ultrasound scan, because cirrhosis, liver cancers have a lot of good treatment, can be cured also, can be operated. There are lots of treatment available. So if you have a cirrhotic patient, make sure that you get an ultrasound scan every 6 months to screen for liver cancers. That kind of a guideline has not still come for fatty liver disease, but that probably will eventually come when the prevalence of liver cancers increases with fat liver. But if you're cirrhotic, definitely you need to have a scan done every 6 months. I'll talk a little bit about the investigations of fatty liver disease. Obviously, as you all know, ultrasound is the basic first-line test that we always do to look for ultrasound scan, to look for fat in the liver. But remember, only if you have more than 20 to 30% of fat in your liver, which will be detected on an ultrasound scan. So just because the ultrasound scan is normal, that doesn't always mean that the patient does not have fat in the liver. You need to have at least 20 to 30%. 20 is, I think, a easy number to remember. Fatty liver disease, everything about 20, 30. So 20, I think you should easy to remember. So if you have more than 20% of fat in your liver, only you will detect on an ultrasound scan. But in obese people, sometimes these detection is also very difficult, because ultrasound scans are not very to detection of fat in the liver is difficult. There are different criteria which the radiologists use for fat liver disease. They grade 1, you would have seen fat liver grade 1, 2, 3. Of course, that doesn't seem to correlate too much with what's happening inside internally. So some people say my fat has gone from stage 1 to stage 2 now, but actually that doesn't truly mean much internally as such, because there doesn't seem to be a correlation between the fatty liver on the ultrasound scan from what is happening inside. So though it's always put in our reports, that sometimes I don't think that we don't take it too much weightage that criteria. Yeah. Also, the scan is very good to look for cirrhosis. So any evidence also in this stage, if the patient develops some degree of chronic liver cell disease, ultrasound scan is good to look for, detect early fat in the liver. The other investigations that we do in a patient with fatty liver disease is the biochemistries, the LFT, the AST, ALT, alkaline phosphatase. That is routinely what we would ask for. And obviously, the other investigation that we do are the routine etiology investigations for chronic liver cell disease, like the ferritin phaimochromatosis. We generally do those investigations. So I'm just going to talk about those things now. Just a little simple things. So the AST, ALT, gamma GT, alkaline phosphatase, all can be elevated in fatty liver disease. Okay, so that doesn't always mean that the patient is having some chronic liver cell disease which needs to be investigated. The STLTs can go up to about 200-300 sometimes when the patients are having fatty liver disease with some hepatitis. Alkaline phosphatase gamma GT can go up. Gamma GT alone can go up. So there are different combinations you can get, but the liver profiles can be abnormal with fatty liver disease. And the other thing is you can have significant damage going on in the liver with a completely normal liver function test also. Lots of times patient comes and says, okay, my liver function is normal. Now I've done my exercise, I've done my dieting, my liver function is normal. That doesn't mean that you can stop there. Your damage still can be going on. So targets are not the liver functions. So it's a metabolic syndrome that we should target. So sometimes just because your normal liver functions does not mean that there is no damage going on inside. The blood tests that I told you, things like ferritin, anti-nuclear antibodies that we routinely do associated with fatty liver disease, also can be positive with, also associated with other chronic liver diseases, can be positive with fatty liver disease in certain percentages. So generally, if a patient comes with high AST, ALTs, we would investigate to look for the causes of liver diseases like autoimmune hepatitis, hemochromatosis, Wilson's disease, hepatitis B, C. So generally we would do those screening investigations. So some of those investigations can be positive in fatty liver disease. So just because the ferritin is high or the anti-nuclear antibodies is high does not mean that the patient is having that other disease, because even like about 20 to 30% of fatty liver disease patients can have positive autoimmune antibodies. So that's something that we need to always remember. This is another investigation which you all will see. Patients might come to you all with what you call a fibroscan or what you call transient elastography. That's available in Sri Lanka in the private sector in Navaloka and government sector in Ragam and Colombo. But that's another investigation. Basically, that does this to, it basically has been or found or invented to kind of replace a liver biopsy. So why we do say if you have fat in the liver, what we do a liver biopsy is to look to see whether there is any damage or hepatitis going on, fibrosis going on. So the fibroscan has been developed to kind of replace the need for a liver biopsy. Okay, if I tell you simply. So basically it has some components which can tell you how much liver fat is there. There's a thing called a CAP score. On that you can say how much fat is there in the liver. And also there is a liver stiffness measurement. On that measurement you can say how much fibrosis. So what we're worried about is the fibrosis or scarring of the liver, which occurs due to fatty liver. So that fibroscan, which can give us idea how much scarring is happening in the liver on a fibroscan. So we do fibroscans sometimes when we want to do a liver biopsy, but obviously liver biopsy is an invasive test with complications. So we do a fibroscan when we want to get that information without doing a liver biopsy. Okay, that's the advantage of a fibroscan. I'll tell you again, there's a bit of algorithm there. We don't do fibroscans in everybody. I'll tell you which patients we should do it, because it's expensive. It's about 18,000 rupees in the private sector. It's very simple. It's a painless thing. Probably takes about 5-10 minutes to be done. It's like a normal ultrasound scan. Just keep the probe on the liver and you get a measurement. If you do it in about 4 or 5 places, you get a measurement. So basically, you get an average. So it's not a difficult test. It's very easy for the patient, but it's costly. So 18,000 rupees. So you're a bit, probably we won't do it in all patients, but in some patients, I'll tell you, kind of which patients we would do it. So again, coming to this slide. So what we, like I told you, so what we want to know is if a patient comes with fatty liver disease, in what state of fatty liver disease these patients are, from what you call normal liver, 10 stage is cirrhosis. So if you look at this, the slide here, you basically, they will be going through what you call healthy liver to a fatty liver, then to NASH, then to NASH with some fibrosis, and to cirrhosis. So when a patient comes to us, presents to us, what we need to find out is in that spectrum where the patient is. That's a difficult thing. So that's why all these investigations are needed, because like I told you, our treatments, our advice is going to be depending on what stage. If the patient is still in fatty liver only, the gravity of our advice is probably not going to be too much. But if the patient is in advanced fibrosis, patient needs to take his disease very serious, because next stage is going to be cirrhosis. Okay, so that's the bit of a difficult thing in fatty liver disease. So to do that, there are different tests, non-invasive tests. So obviously liver biopsy is going to be the best. If you take a piece of the liver and you go to the microscope, you can basically look and say, okay, there is a lot of, this amount of fat is there, this amount of hepatitis is there, this amount of fibrosis is there. But we can't do liver biopsy in all the patients. So to avoid that, there are certain what you call non-invasive tests, like blood tests or scans, which have been developed to get that information out. Like as ultrasound scan basically tells us that there is fat in the liver. This transient or the fibroscan I told you also can give us that information of how much fat is there in the liver. Then there are different indices called, I'm not going to detail, but there's this fatty liver index, NAFL liver fat scores. There are different indices which have been developed to give us an idea of how much fat is there in the liver. Again, to give that information to the patient. Right? MRI scan is probably the best to quantify how much of liver is fat is there in the liver. But again, MRIs can't be done in everybody because of the cost, right? But if you ask for what is the best test to quantify the amount of fat in the liver, it's probably this. There is a special MRI, but MRI is the answer for that. To look at the fibrosis of how much scarring is there in the liver, again, there are different non-invasive tests. Like I told you, because fibrosis is most important thing, because if you have fibrosis, that's when people start getting all the complications of liver cancers and portal hypertension and so many other problems. Okay. Again, traditionally we looked at the AST, ALT. Okay. Normally the ALT is more than AST. If you look at all the reports, but when the patient starts developing fibrosis or scarring, the ALT starts coming down and the AST starts coming up. Okay. And when it starts reversing, that's when patient, we tend to think they have cirrhosis. So if you look at a cirrhotic patient's AST, ALT, typically the AST will be more than ALT. Not always, but if it is there, that is very suggestive this patient might be having cirrhosis. But there are, that's not always there. Sometimes you can have the ALT more than AST also, but usually what happens is the ALT starts coming down, AST goes up. Okay. And that's, so if you look at the liver functions on a repeatedly, if you look at the serially, if you look at the AST, ALTs, you probably can get an idea whether this is happening, whether the patient is developing some scarring in the liver or not. That's another non-invasive way to look at whether there is scarring happening and the patient is going on to develop cirrhosis. And again, there are different scores like the FIB4 score, which I'm going to talk about a little bit today, and the NAFLD fibrosis score. Then there are different biomarkers, blood tests like cytokeratin 18. Then you get the, again, like the fibroscan I told you about, the MRE scan. There are different other imaging modalities, which can also give us that information of how much liver scarring is happening in this patient. Okay. I hope I'm not making it too confusing, but so basically these are different non-invasive tests to tell us this is amount of fat is there in the liver, this is amount of damage is happening in the liver, without actually doing a liver biopsy. Obviously, gold standard, like I told you, is a liver biopsy, but we can't do liver biopsies in all patients. because it leads to complications. Patient can even, there's a probably 1 in 10,000 chance of mortality even with liver biopsies. So we can't do liver biopsy. We do in a selected people liver biopsies. We do in patients when we are not very sure. We do all the non-invasive tests, and when we are not sure whether this is fatty liver or there is probably some hepatitis, other hepatitis going on, or there is some autoimmune disease going on. So when we are not very sure that this is just plain and simple fatty liver disease, then only we'll go and do liver biopsy. So liver biopsy is done in a very selected group of patients. Right. This is, I think, a slide which probably hopefully you all can keep in mind. So if you all get a patient with fatty liver disease, okay, once you all take the history, get the alcohol history, look for other causes of steatohepatitis, like I told you, like the tamoxifen, the drugs, maybe alcohol, maybe other hepatitis. So look for other reasons for whether there's fat in the liver going on. And then you look for other reasons for chronic liver cell disease. And those patients, you do what is called this FIB-4 score. Okay, FIB-4 score is not difficult. It's basically, if you all have if you have a smartphone, basically it's a very simple thing. You do a search for FIB-4 calculator, and so all the patients with fatty liver who come with you get the AST, ALT, and the platelets and their age. Basically, you need 4 parameters. Okay, age, AST, ALT, and the platelet count. You put that into the basic calculator. If you have it, basically you can just do a Google search, FIB-4 calculator, it gives it. And then it gives you a score. It happens within 10 seconds. And you get that score. And if that score is less than 1.3, those people are at a low risk of developing this fibrosis, this scarring process. If the score is more than 1.3, those people are at an intermediate to high risk of developing this scarring process. And that's the group which you need to try to refer to a specialist, maybe a gastroenterologist, or somebody who's interested, because those people need evaluation. All the other people can be managed in a primary care setting by giving different advices, which I'll allude to later. So if all your fatty liver disease patients, if you can do this FIB-4 score, it will be very useful to differentiate which patients need further more specialized management, or which patients which just need the basic lifestyle modifications only. Okay. Sorry. So coming to the management basically involves 4 areas, basically lifestyle modifications, then targeting the metabolic syndrome, because I told you metabolic syndrome is a big component of fatty liver disease. Then trying to see whether there's a drug which can reduce fat in the liver, and managing the complications of this fibrosis or cirrhosis. So if you look at the lifestyle modifications and look at the diet, the optimum diet for fatty liver is still not known. Okay, but what we need to do is try to make sure that they have a reduced calorie diet. So try to reduce their calories by 30%. I mean, if you actually can refer them to nutrition, dietitian probably is good. So they need to reduce their the calorie intake by at least about 30% of their normal diet. Okay, so obviously we know about the Mediterranean diets, the avoiding of saturated fats, the simple carbohydrates and sweetened drinks. So fast foods, all these things need to come out of their diet. Okay, so that's a diet which which we kind of think of we say as a healthy diet. And so that's about the diet. Basically, what I tell patients, especially, I mean, Sri Lankan people don't always, I mean, probably in the urban population, they would go and eat fast food. But what I tell patients is, if you get your rice plate, because most of patients would eat rice almost three meals, serve your vegetables, proteins, do all that, and serve your rice last, because the carbohydrate is the culprit. It's not actually the other things. And then you have not much space to actually serve your rice, and you would actually have a full plate. What happens otherwise is you serve your rice and you put your other things above it, and then you have a full plate of rice and all the vegetables and proteins also. If you do it the other way, you eat less rice. So, and psychologically, you feel that you've eaten a complete plate also. Because I think psychology is very important, because all your gut hormones, everything matters on our psychological stimuli. And otherwise, if you tell them eat only 2 spoons of rice and other things, then they would take, are you doctor? Because that's also due to psychology. So that's what I tell at least my patients, do it the reverse way. It helps. I think it helps. So if you look at weight loss, you need to target a 7 to 10% weight loss. Okay, because that's the kind of weight loss which are shown to improve all these different the damages which happen in the liver. Okay, if you can actually go for 10% weight loss, the damage that they even have shown that fibrosis, the scarring can be reversed. Previously, if you remember the teachings a few years ago, liver scarring was never reversible. Cirrhosis was never reversible. But now they are shown even the scarring can be reversed with treatment, even with fatty liver. There are other conditions like hepatitis C, autoimmune hepatitis. They say with the treatment, you can reverse it. So scar tissue can be reversed. So more weight loss, more improvement. Okay. What sort of physical exercise should be given? Anything. So aerobic, anaerobic, resistant exercise, anything. Okay. Generally, what they say is 30 to 60 minutes a day, or 150 minutes a week. You can put in different ways, or 10,000 steps a day. Okay, 30 to 60 minutes a day, 150 minutes a week, 10,000 steps a day. Different people can do it in different ways. But you need to do some exercise. You need to incorporate exercise into your normal lifestyle. It can't be a special thing that you do. And people who can't walk, you can do resistant exercise also. If you have difficulty in exerting yourself, you can just do resistant exercises, which will help increase insulin resistance or reduce insulin resistance actually. Okay, so some sort of exercises is needed. I tell patients, so walking, swimming, jogging, cycling, whatever that they prefer. Okay, as long as it increases the heart rate. Okay. What about the pharmacological treatments? There are lots of treatments, obviously, I would have seen which are available. Drug reps come and tell this is good, that is good. But unfortunately, most drugs don't seem to be much useful in fatty liver disease. There's a certain group which seem to benefit from fatty liver disease, from drug treatment in fatty liver disease. Okay, people who are having progressive fibrosis. Okay, so if you have advanced fibrosis, those people giving pharmacological treatment is useful, but not in everybody. As you would see, everybody fatty liver disease, they're on vitamin E or there's something. So that's not actually indicated. What is indicated is the lifestyle changes. Just to highlight, most guidelines, if you look at all guidelines, they indicate pharmacological treatment only if you do a liver biopsy. And I told you liver biopsy done in a very selected group of people. So only those people, medicines are indicated. All the other people, medicines are not indicated. So vitamin E, as you know, is the most commonly used drug in treatment of fatty liver disease. The dose is 800 units a day. Okay, we commonly prescribe only 400. Okay, so if you're giving it, you have to give 800 units a day. Okay, it has been shown to improve damage going on in the liver. Okay, but the problems of vitamin E is there are other side effects. They can increase prostate cancer. They can cause subelectron hemorrhages, intracerebral hemorrhages. So there are certain side effects with giving vitamin E high doses, okay, which we don't actually think about too much. So before giving vitamin E, think twice without just freely giving vitamin E. Unfortunately, in Sri Lanka, just dishing out just advice doesn't seem to work in our patients. Our Sri Lankan patients want some tablet. I spend about 15 minutes and they ask, Dr. Behetned. So that's our psychology. So I guess giving a harmless small dose of some vitamin is probably okay in a cultural, Sri Lankan culture. But if you look at actually the way this indicated, probably it's not. Okay. Statins, a lot of people who have fatty liver disease with AST/ALTs, lot of times statins are stopped because thinking it's not good for the liver. Actually, it's good. It is actually good for the liver. Okay. So AST/ALTs being high does not warrant statins to be stopped. You can actually continue the statins. It's probably going to be useful for the liver, not just for fatty liver disease, but if they have fatty liver disease with hyperlipidemia. So if there's another indication to give statins, you can give it, but not per se to treat fatty liver disease. Okay, so any patient come with raised liver enzymes, unless they are in thousands and the patient is in like liver decompensation, you would not give statins. But otherwise, if the AST/ALTs are 100, 200, there's a good indication to continue statins. You don't need to stop statins. Ursodeoxycholic acid. Ursodeoxycholic acid, again, another drug used by a lot of people because it seems to improve the AST/ALTs. So in a patient's viewpoint, his fatty liver has been treated. But again, there is no studies that it actually improves what is happening internally. So again, not indicated. Omega-3 fatty acids, again, probably not indicated, but again, a drug which is used. Metformin, again, if the patient is diabetic, yeah, you can use it, but not just for fatty liver disease. There are no studies which are shown that metformin is useful, just plain and simple fatty liver disease. Pioglitazone is a drug which seems to be useful. Okay, vitamin E and pioglitazone are the two drugs which have at least come some close to treating fatty liver disease. So if the patient is diabetic, actually it has been shown in non-diabetic patients also. So if you are diabetic, pioglitazone is a drug which can be actually used to treat fatty liver disease and diabetes, because pioglitazone has been shown to improve fatty liver disease, the damage which is happening inside, 30 milligrams a day. But again, remember the side effects: weight gain, edema, osteoporosis, bladder cancer. There are other problems also with pioglitazone. So you can't just dish out to everybody. You have to be careful. There are whole loads of vitamins which are given for fatty liver disease. Remember, have no place at all. I'm not going to go to the trade names. There are silymarin, there is different drugs, okay, which we have basically rejected registration, but they somehow take some way and come back into the market. Sri Lanka has so many different types of not vitamins, I think they are supplements, I think, which are shown to be proved this drug risk commercially, they are good for the liver, but remember, no studies have proven them. There is no benefit at all. Again, probably harmless drug to give it to the patient. Okay, we giving something, but personally, I never prescribe any of those things. There is no benefit at all. Obeticholic acid is another drug which has come close. Probably drug reps might come and tell you obeticholic has a lot of good effects, but again, it's registered in Sri Lanka in the market, but again, it's only in a selected group of people with advanced disease that you would give them, not routine in all patients. Okay, I'm not going to detail about these things, but again, not in all patients. So that's my last slide. So basically, if you get a patient NAFLD, make sure that you screen them for metabolic syndrome, get their blood pressure. That's more important than actually treating them, giving them a vitamin. Okay, get their blood pressure checked, which you all obviously do. Get the blood sugar checked, the cholesterol checked. Okay, and do obviously the appropriate other investigations, and do the FIB-4 score. It's a very easy score. If you do the FIB-4 score, you can actually risk stratify them and refer the patients to the relevant people as needed. And spend some time, 10-15 minutes at least, trying to tell them, okay, this is about lifestyle modifications and not about treatment. So they need to change their diet, change the exercise, change their daily routines, have a good sleep, basic things, okay, which will actually help. And it is not something which can be done over 3 months. A lot of people say, Dr. Man, baradu karagatta, hari, masa tuwing kara. That is doesn't work. It has to be something which is going over 10 to 15 years, because the disease is going to be there for 10 to 15 years. So it's a slow process. That kind of a message needs to be given to the patient. Thank you.
Since Dr. Nilesh needs to leave, I think we can have a few questions. Anybody in excellent presentation, and stay on the website very soon for you all to watch it. If any questions are there, burning questions, you can ask and Dr. Nilesh. In that, anybody? So I think your lecture was excellent.
Spoil the dinner, I think.
Yeah, and so since no question, that means everybody has understood or no one has understood.
Yeah.
Right. Before I permit you to leave, let me hand over a token of appreciation from the IMPA. Unfortunately, our secretary is not here, so I will do the secretary's job. Thank you. Thank you very much. Our next lecture is by Dr. Niranjala Migoda Vidhanage, who is a consultant endocrinologist And she's presently attached to the Colombo South Teaching Hospital, Kalubola. She has an MD, MRCP, and FCCP. She was a consultant endocrinologist at Anuradhapura Teaching Hospital for about 10 years, and she had a foreign training in Oxford. She has given a very short CV. So, and her topic is update on diabetes management and insight on the diabetic diet. Over to you, madam.
Thank you very much. I would like to thank the Independent Medical Practitioners Association and board for organizing this and inviting me to be a part of this program. So I will take you through some of the important things related to diabetes, and because I know diabetes is a very hot topic, so everybody wants to listen to something new. So I will be taking you through on a little bit about the diabetes epidemiology, treatment, and the latest management algorithm by the EASD. And then a few things about the diet, based on what we decide which food is good and which food is bad. So I think that is the basis of the prescriptions for the diet. So I will take you through briefly on these things. Okay, so this is the IDF Atlas, which was published in 2019. This atlas depicts the number of diabetic patients living in the world. So in 2019, actually, there were 463 million diabetics. Now now we are living in 2021. Now there are more than 500 million, that is more than 500 million diabetics living in the world. So what I want to highlight here is, you may see by region wise they have color coded and they have put the numbers, and this very small region in this is not very clear actually. Can you focus it a bit? The picture is not very clear. So in our Southeast Asia, which is shown in red color, this part, where is the pointer? Is there a pointer here? Yes. So this red color part is the Southeast Asia where we are living. You will see that it's a very small region when compared with the other parts of the world. And we have 88 million diabetics living in this part. So if we are to compare this with Europe, you will see this dark blue area is the Europe. There are 59 million diabetics. So in such a massive region, if there are 59 million and compare with the small region, we have 88 million diabetics living, not only in our part, all the other developing areas like the Middle East and North Africa and the African area. So there are a lot of diabetics are clustered there, plus the rate of the increment. So you may appreciate that in Europe, in the whole world, it's a 51% increment they have calculated for the next 25 years or so. So they expect the world will have about 700 million diabetics in 2045. And the increment in Europe is about 15% over this next 25 years. And in our region, it's 74% increment. So you will see that it's a very massive, big burden for the health economics in the whole world. And being a poor part of the whole world, we are especially burdened by this disease. And apart from that, 1 in every 5 adults, already in our Sri Lankan epidemiology also says that every 1/5 adult is a diabetic. That means almost like more than 20%. Now actually in urban and suburban areas, it's about 26%. That means all 1 in 4 adults has a diabetic. And to worsen the situation, every 1/4 birth is affected with the mother having hyperglycemia. So it's common for the whole region, not only for Sri Lanka. So we are especially burdened being Asians. Then I would like to take you through the available oral hypoglycemic agents. And next slide, I will take you through the recent updated glycemic algorithm, control algorithm, which I thought will be important for your point of view. So these are the commonly used medications. No wonder metformin is always in the first line, because metformin is cheap, and we know that there are a lot of concerns about the other added benefits of metformin apart from the glycemic control. So I will take you through these groups of drugs. Some drugs are not available in our country, but I will take you through the important few things highlighting main drug groups. So metformin, when it comes to metformin, actually metformin is a very good drug because it does not cause any hypoglycemia. We are mainly worried about hypoglycemia with other drugs such as sulfonylureas and insulin. But metformin never causes hypoglycemia, even if it is used in non-diabetics, because we sometimes use metformin in non-diabetic populations, especially the women with subfertility and polycystic ovarian syndrome. And there are some other concerns about like in fatty liver, like Nilesh explained, but it's not recommended, but off-label, some people still use it, even for weight reduction, because metformin is, in the other hand, it is weight neutral or is associated with some weight reduction. So most of our diabetics are obese, especially our type 2 diabetic female population, they're obese. So obesity in many ways impair the glycemic control and predisposes a person for metabolic syndrome, not only for diabetes. Therefore, the weight is a key issue when it comes to managing obese type 2 diabetic people. So metformin is a very good drug because it is associated with some degree of weight reduction. If at all, it never raised the weight. Then it has no adverse bone profile and it has no problem with the cardiac disease. And it doesn't cause any ketoacidosis. Those are the other benefits of metformin. Apart from that, they have not mentioned here, but for the lipid profile also metformin has a great benefit because metformin is associated with suppression of some enzymes involved in lipid synthesis, like the HMG CoA reductase, lipid acid, fatty acid synthase, lipid carboxylase. All these enzymes are suppressed by metformin. Therefore, it has some beneficial effects on lowering triglycerides, LDL, and VLDL. And apart from that, it has some increase in beneficial effect on LDL cholesterol. Therefore, metformin in many ways is beneficial. And the only contraindication for metformin is the renal disease that is also moderate to severe, that is with eGFR of more than less than 30. We do not recommend initiation or continuation of metformin. The other drugs, other group of drug which I would like to mention is the GLP-1 receptor agonist, which you may not be very familiar with because it's not being used in Sri Lanka. And it is an injectable drug. So if it is an injectable drug, why not insulin? That's what we feel because insulin is freely available, cheap, and it is even given in the hospitals. But as I told you at the very beginning, the weight is a problem with insulin because insulin is notorious to cause weight gain. We know that most of the people put on weight with insulin. And insulin is associated with hypoglycemia. The risk of hypoglycemia is more with insulin. But GLP-1 receptor agonists, that is exenatides, liraglutides, IDE, you know, those are the drugs of GLP-1 receptor agonist group. Those are not associated with any hypoglycemia. Apart from that, it is again not associated with any weight gain. It's in fact, it helps some weight reduction. Therefore, and the other benefit is there are injectable exenatides which can be given weekly. Therefore, that benefit is also there if we are to use. But there are few people in Sri Lanka who use exenatide or GLP-1 receptor agonists, but it is not freely available. They have got it down from other countries, and there are few people in the private sector who are using mainly for those benefits. And it has some beneficial effects on the renal profiles also. And it's known to reduce the proteinuria and progression of renal disease. Therefore, GLP-1 receptor agonists are very important in people with some early renal disease. And adverse effects profile wise, some gastrointestinal problems are there, even with metformin. That is the main drawback of metformin use, because we know that nausea, vomiting, loss of appetite, some gastric irritation, those are the main problems. And constipation, some patients develop loose motion. So all are related to gastrointestinal system. And this exenatide also, like GLP-1 receptor agonists, are also known to cause some gastrointestinal problems. And then actually, sulfonylureas are the other important group of medication that I would like to mention, because that is freely available, given in the hospitals, and very potent when it comes to sugar reduction. Sulfonylureas are the most potent. So there are first generation, second generation, and now third generation sulfonylureas, minimizing its problems, because the main problem with sulfonylureas is also its weight gain. Like insulin, it is also known to cause weight gain. Again, and then it will be a problem in our patients who are obese already. And the other problem is the risk of hypoglycemia. It's especially seen with the first generation sulfonylureas like glibenclamide, especially for frail old people with a lot of other associated comorbidities. This hypoglycemia risk is a very dangerous problem, and especially when once experienced, most of these patients will be very reluctant to go for oral medications or insulin. Even with insulin, that is the main problem. So once experienced, the people get very scared. It's a very dreaded complication of glycemic control, actually. So rather they will prefer not to be on any medication rather than experiencing a severe hypoglycemic episode, rendering them to be hospitalized and getting unconscious. So getting scared, the whole family being terrified of using any oral drugs or insulin. So the sulfonylureas, the main problem is the weight gain and the risk of hypoglycemia. And then the SGLT2 inhibitors are there, which is a very attractive option. You all are familiar with SGLT2 inhibitors. This empagliflozin, canagliflozin, and dapagliflozin. Those are the drugs that we commonly use. So it's a very attractive option. The only problem is it's very costly. But with time, the cost will come down, like the DPP4 inhibitors initially when the sitagliptins came, linagliptins, sitagliptins. So it was very expensive at the very beginning. And it was the major drawback to initiate a patient on a DPP4 inhibitor. But with time, the cost came down. Hopefully, the SGLT2 inhibitors also will become attractive with the price reductions in the future. So the main benefits of SGLT2 inhibitors are like it also has a weight neutrality, or it reduces weight basically, and it has a blood pressure lowering effect. And it's very effective, especially for those patients who are on insulin. Sometimes they, even with a very high dose of insulin, some are not getting adequately controlled. But when you add a small dose of SGLT2 inhibitor, the sugar and the insulin sensitivity is really, really improved, and the patient's sugar control becomes really easy. But again, the problems with the SGLT2 inhibitors are that they can become polyuric and become hypotensive. And more than that, they can have some genitourinary infection. So if you start a patient on SGLT2 inhibitor and the patient comes and tells you that had some genital itching, irritation, so be mindful that this is most likely because of the SGLT2 inhibitors. Very well-known side effect, which most of our patients experience, and sometimes there is no way out other than discontinuing SGLT2 inhibitors. There's some problem with the slides. And then there are other groups of drugs like pramlintide, which is an amylin analog, which is not used in our country, but it is a very good drug, which reduces the insulin resistance. Yeah. And improves the satiety. So there are a lot of important drugs, important features in this pramlintide, which is attractive, but it's not available in our country. And there are some other groups of drugs like pioglitazone. Actually, I heard Nilesh mentioning that the glitazones are associated with bladder cancers, but that risk is not there. Actually, initially it was withdrawn from the market in India, and then USA also withdrew it for a while because there was some concerns about the bladder cancers. Then actually there were a lot of reports which came up and a lot of research data, and the meta-analysis clearly showed that pioglitazone is not associated with any bladder cancer risk, because that is very safe anyway. But mind you, we cannot use it in heart failure, and when the patients get edema, and it's known to cause some retinopathy problems like retinal edema and maculopathy, and osteoporosis, risk of some fractures. So those are the problems with pioglitazone, but it's a very attractive option, especially when it comes to the reduction of postprandial glycemia. So but it is not given in combination with insulin. We have to know that. But I have seen many people initiate them on insulin, but when their prandial sugar is high, they are still initiating them on glitazones, which is not recommended, none of the guidelines. So I will take you through the guidelines in order to show you the combinations and how and when we should decide on what and which drug and how much to give. So this is the EASD latest guideline for the algorithm for the management of glycemia. So it's not always the same. Like in the past, we thought, okay, for everybody, HbA1c should be less than 7%. But now the goals are individualized because there are a lot of factors that we have to consider. And it's not 7 anymore, like because they have found that even HbA1c 7 is associated with some adverse events. Therefore, the glycemic targets are set now to less than 6.5, but not for all. The people who do not have high risk of developing hypoglycemia, who do not have a lot of comorbidities, associated comorbidities, who are motivated, willing to try very tighter glycemic control, that kind of patients, the HbA1c target is less than 6.5%. But for those who run a high risk of developing hypoglycemia, who are very old and frail, they have a lot of other comorbidities, then the hypoglycemia is a major problem in those patients. Therefore, the lowering of HbA1c to less than 6.5% is not recommended. Their targets are less stringent. Probably they can be set into even up to 7.5, 8%, because in very old person, our concern is not to get their HbA1c to below 6.5 in order to prevent complications which will be developed 20 years or 15 years after. Our aim is to keep them comfortable as much as possible without any osmotic symptoms and short-term complications like developing diabetic ketoacidosis and recurrent hospitalization, infections. So in order to prevent these things and to keep the person comfortable, our glycemic targets are set depending on their other things considering. So in general, if a person comes to you, how to decide on, that is what the rest of the algorithm says. Anyway, for everybody, lifestyle modification is indicated, like exercise, the diet, cutting down alcohol, cessation of smoking. All these things should go hand in hand with the other medical management. And with that, the entry HbA1c and the presence of atherosclerotic cardiovascular disease or risk of other cardiovascular problems and the renal diseases. Those are the things that we consider when we are initiating a person on oral hypoglycemic agents, oral or injectable hypoglycemic agent. In other words, injectable I call insulin and GLP-1 because both are injectable drugs, not only insulin. So the entry HbA1c, if less than 7.5, the recommendation is to go for monotherapy. That means one drug, if the HbA1c is less than 7.5%. So most of the time, metformin is the first line medication unless contraindicated. Like what I told you at the very beginning, metformin is contraindicated in case of renal failure, like if the eGFR is less than 30, moderate to severe renal disease. Other than that, the other factors which we consider is the presence or absence of cardiovascular and the renal problems. If they have already established heart failure with reduced ejection fraction, or if they have atherosclerotic cardiovascular disease or high risk for the development of atherosclerotic cardiovascular disease, then actually SGLT2 inhibitor or GLP-1 receptor agonist are the first line agents the guidelines recommend. But in our country, as I told you, GLP not available, SGLT2 inhibitor is quite costly. Therefore, we can still go with the metformin as the first line. So presence of renal disease is another key issue, but if their eGFR is less than 45%, we can start them on SGLT2 inhibitors. And if it is less than 30%, we can't give them GLPs. But if they have any renal or cardiac problems, the first line drug is GLP or SGLT2 inhibitor. Otherwise, in our context, actually, we can start them always on metformin as monotherapy if they are presenting entry A1C is less than 7.5%. Then comes the next group whose HbA1c is between 7.5 to 9%. If the HbA1c is between 7.5 to 9%, then the recommendation is to go for either dual or triple therapy. So that means 2 drugs in combination or 3 drugs depending on their glycemic profile. but metformin is the key again. Then you can add on another therapy. But here, of course, there are a lot of other drugs to be added. As I mentioned, if there are cardiovascular and the renal, then SGLT2 inhibitors in our countries is the best option, considering the affordability. If the patient can afford, and in the private sector, of course, you can add the SGLT2 inhibitor as the second line medication. But as a third line, always you can go for insulin without any problem. And that also what they recommend is initiation of a basal insulin, not the premixed or soluble insulin, which has to be given quite frequent, because you might have experienced how difficult it is to initiate an injectable drug in our patients. The minute you mention insulin, the patient is lost for 6 months minimum. That is my experience. So they again come back with a lot of other complications. They go doctor shopping, they go to this doctor, that doctor, everybody thinking that they will have some way out with oral drugs. So at least to prevent that, we can initiate them on a basal insulin, because that has to be given once daily and at bedtime. Mostly that time, some patient relations will be at home, the family members will be there. So at the beginning, somebody else can help injecting. But in the morning and noon, if you start on, there will be a big problem, because the patients are very morbidly scared. Our patients are morbidly scared on needles. So that is another thing that we have to consider. And then if the entry A1C is more than 9%, how do we decide on what drugs to use? So that then we have to see whether the patient is having a lot of symptoms of hyperglycemia and hypercatabolic state, like they are wasting, they have polyuria, nocturia, polydipsia, lot of osmotic symptoms related. Then actually they have to be, the recommendation is to go for insulin at the very beginning. So go for insulin, and then depending on their response, we can up titrate or we can move back and go and start them again on some oral medications. But with insulin, you can always combine some oral medications, either dual or triple therapy. But depending on the patient's glycemic level, sometimes if their presenting glycemic level is more than 500, we have come across enough patients like that, then actually we can start only insulin, then not a basal insulin. Actually, we can start them on a premixed insulin at least twice daily to begin with. Depending on their response, then we can upgrade, up titrate the insulin. No, we can gradually add some oral drugs. And if the patient is very reluctant to be on insulin, and if the initial glucose toxicity has been removed, then we can go back for oral medication. So that is the way this algorithm has been explained, and that is the usual common practice among us also. So now we'll move on to the interesting part, which, as I told you at the beginning, based on what we decide on what food is good and what food is bad for diabetics. So as we thought, this Dr. David Jenkins also thought, how do we decide on which food is good and which food is bad? Then based on that, he found these two concepts, the glycemic index and the glycemic load. So what is this? What is this glycemic index and what is this glycemic load? So there are two studies which have shown very clearly that if you consume a high glycemic food with high glycemic index, that is basically, if I am to simplify, let's say something with a lot of sweets and refined sugar, if you consume it over many years, you are likely to develop diabetes, type 2 diabetes, more likely to develop diabetes, because in the past, the people thought no matter whatever you eat, you don't develop diabetes, but it's genetically modified. Like genetics are there. I think about 30% of type 2 diabetes have some genetic background, but consuming a lot of this refined sugary and starchy things over a long time also will increase the probability of a person who has otherwise has no genetic predisposition also to develop diabetes. So these are two studies, that Shanghai Women's Study and the Black Women's Health Study. Those two studies have clearly shown that you run a higher risk of developing diabetes if you consume the food with high glycemic index over a long period. Okay, so in simple terms, this glycemic index means if you eat some carbohydrate, how your blood glucose level will rise. Basically, when you eat some food, how your sugar will behave in your blood. So that is what the glycemic index is. But there is a special way of calculating. So it is defined for each type of food and independent of the amount of food which is consumed. This glycemic load accounts for the amount of food. So index is not depending on the amount. The load is depending on the amount. So just remember those two things, because when I'm doing the rest, you will understand it better. So how do we calculate the glycemic index? So we keep a person 12 hours fasting. Then we have the standard and the test food. So the standard is always either glucose or white bread. You get 50 grams of carbohydrate, you give it to the person and plot their glucose rise. Like the next slide I'll show you. So this is what is done. So this yellow one is that orange one is the standard. So if you give the standard 50 grams of glucose or 50 grams of glucose containing white bread at time 0, then you plot the glucose level against the time. This axis is time, this is the glucose level. We know a healthy subject will not raise their blood glucose above 140 with whatever the glucose load they are getting. So let's say that this person is given the glucose 50 grams and they plot their glucose rise against time. So you will see that the peak is around 140. So these are arbitrary just for you to understand. So at 100 and the blood sugar rise to 140 in 50 to 60 minutes. That is within about 1 hour. Then it gradually comes down because the insulin starts secreting. Then all these mechanisms of glucose lowering comes into play. Then their sugar is brought back to their normal level. So that is what happens. So this blue graph is for the test food. Let's say we take food with the low glycemic index, for example, beans. So this person is fed with another load of beans, which has 50 grams of glucose, the same amount of carbohydrate. So the person takes it and the sugar is plotted again against the time. So you will see that the peak is much lesser than the person who got the standard, the white bread or the glucose. And the time taken to reach the peak is much longer than the standard. Can you see? So within 1 hour, let's say the person who ate glucose 50 grams got 140. And the second person, the one who took 50 grams of carbohydrates in the form of beans, or let's say bean seeds, had their maximum glucose around 100 and the peak came within about 2 hours. So this is the difference. So this is how you calculate. Then the glycemic index is calculated with the area under the curve for the test food on top of the line and the area under the curve for glucose or the white bread at the bottom and multiplied by 100. This is how you calculate the glycemic index. So these are the food which has high glycemic index and the low glycemic index. So the food which has high glycemic index break down quickly, like the people who got the white bread or glucose, and the release glucose rapidly into the bloodstream. And the people who had the food which has low glycemic index break down slowly, release glucose more gradually into the bloodstream. So these are the food, roughly, these are the things that has a low glycemic index, and these are the food that has a high glycemic index. So there are certain other properties in a food which has which alters the glycemic index of that particular food. So the type of the starch. We know that the starch exists in our food in the form of amylose and amylopectin. Amylopectin is easily digestible. So amylopectin, if is more in your starch, absorbs faster. Then what happens to the glycemic index? Low or high? High. It has a high glycemic index if the food is, your carbohydrate is rich in amylopectin. And similarly, the physical property of the food also has an effect on the glycemic index. For example, if you eat a lot of vegetables, fiber-rich things, you have that the absorption is delayed. Then that also lowers the glycemic index of that particular food. And the fat and the protein content in the food. The fat and the proteins also delays the absorption of the carbohydrate. Therefore, that also lowers the glycemic index of that particular food. And some organic acids, such as adding vinegar, those also lowers the glycemic index. So there are a lot of other things, not only the property of the carbohydrate, there are a lot of other things in your diet which has an effect on your glycemic index. And presence of dietary fiber slows gastric emptying rate, lowers the glycemic index, and these things I have explained. So the food which has a lower glycemic index, when there is a low glycemic index, slow the rate of digestion, slow the rate of absorption, greater extraction from the liver and the periphery, lower insulin demand. And apart from the glycemic benefits, this low glycemic index food has other benefits like improving cholesterol levels, prevent heart disease and certain cancers, and help to lose some weight. Therefore, the food which has a low glycemic index has not only benefits in the diabetics, but it has some other added benefits also. So when we classify the glycemic index, the figures which are less than 55, we consider those food as the food which has a low glycemic index, and the medium glycemic index, if the figure is between 56 to 69, anything above 70 has a high glycemic index. There are a few things on this slide which I want to highlight. So you may see the fructose. What is fructose? It is the sugar which we find in fruits. So that is why, though the fruits are very sweet, still diabetic patients can consume a moderate amount of fruits because the fructose has a low glycemic index. And the whole wheat products, basmati rice, baked potato, sucrose. Sucrose also has a medium glycemic index. And this white bread, most white rice, cornflakes, cereals, glucose, all these things have high glycemic index, as we all know. So what are the clinical uses of glycemic index? Is it always very useful? Then came the question, how useful and practical the glycemic index is. So the food that has low glycemic index releases glucose more slowly, and it is more acceptable in postprandial hyperglycemia because most of our patients have very high glucose surges following meals. Therefore, to lower that, this glycemic index, the food with low glycemic index could be beneficial. That is one thing. And when, let's say, somebody is experiencing a severe hypoglycemic episode, then we cannot correct that with food with low glycemic index because we need a rapid correction. So this is another clinical implication where knowing a glycemic index will be important. Therefore, the correction of hypoglycemia, we will have to always use something which has a high glycemic index because that will get rapidly absorbed and will correct the hypoglycemia rapidly. So what is the effect of alcohol on your glycemic index? Alcoholic beverages are known to have low glycemic values. Beer has a moderate glycemic index, but they have found that consuming moderate amount of alcohols just prior to a meal will lower the glycemic index. But if the alcohol is consumed about 12 hours prior and in large quantities, will not have that benefit. Like Nilesh mentioned, I saw that for women it's 7 units per week, and for males it's about 14 units per week is the healthy cutoff. Like for this also, the alcohol in moderation, that is within the acceptable level, has a beneficial effect in lowering the glycemic index if consumed just prior to a meal. So how practical is the glycemic index? As I told you at the beginning. So that can be applied only for the food which has a substantial amount of carbohydrate, isn't it? What about the food that we consume which has no carbohydrate? How can we predict about the quality or whether it is good or bad? So we cannot apply it for all the food. And because and the other problem is that most of the vegetables and the fruits we consume, especially the vegetables, has a very little carbohydrate. So to give that carbohydrate 50 grams, how much of that particular food we have to eat? So that problem came up. So then they looked for this glycemic load. which is calculated for a serving. Per serving, because it is calculated per serving, that could be applicable for the whole day, even for many meals, or else quantities wise, even if the quantity is doubled or tripled. So this was very practical in the point of prescribing a diet, they found, because the glycemic index is very practical in the form of research and to find out which food is having high glucose and all. But to give you a small example, for you to understand, if we take watermelon, so let's say that watermelon has a high glycemic index, because we know that 50 grams of carbohydrate in watermelon, if you give, that will raise the blood sugar very quickly. So that glycemic index is very high. But who will eat 50 grams of glucose containing watermelon per meal? Because to calculate, to get that 50 grams of glucose, you may have to eat about 5 kilos of watermelon at one go. Nobody eats 5 kilos of watermelon, isn't it? Therefore, the glycemic load in a watermelon per serving, which is calculated, is very low. So the glycemic index is very high, but the glycemic load is low in watermelon. So with that example, I hope you have understood what the glycemic index and the glycemic load is. So the glycemic load became more practical because that is calculated per serving. So anything that, whatever the amount we eat is what is going to matter, isn't it? So anybody, any diabetic patient can eat a piece of watermelon without having raised blood sugar, because the glycemic load is very less, because we eat the quantity which has a little bit of sugar. So when we are calculating glycemic load, so the grams of available carbohydrate in the edible portion of food, edible portion, the amount that we serve, usually what we eat, multiplied by glycemic index divided by 100. This is how the glycemic load is calculated. Then the glycemic load, when it comes to the cutoffs, we consider less than 10 as low, 11 to 19 as medium, and more than 20 as high. So this is the cutoff values for the glycemic load. So there are a few interesting things about the glycemic load, because it's beneficial in dietary programs targeting metabolic syndrome, insulin resistance, and weight loss, because it's calculated for a per portion size. And for diabetics, glycemic load is a highly recommended tool for managing blood glucose. And it can help to avoid the onset of type 2 diabetes mellitus, because we have, as I have mentioned at the beginning, consuming the food which has very high glycemic index for a long time can predispose a person to develop diabetes, even if that person is genetically not predisposed. So I have taken, for the sake of interest, some data from the Department of Biochemistry at University of Sri Jayawardenepura. They have done some studies over the commonly used Sri Lankan food to see what the glycemic index and the glycemic load is. So there are some surprising and interesting things in these two slides. So it's going to be last couple of slides on my presentation. So there are some interesting facts which may be new to all of you, which we have not thought of. So that kind of things. That is why I thought I will take this slide and show you what the glycemic index and the glycemic load is in certain food. So you will see, as we all expect, the white bread, and the white bread has a very high glycemic index and high glycemic load. So what about red rice? So we all happily ask our patients to eat red rice. It also has a high glycemic index and high glycemic load. But if it is eaten alone, so nobody eats red rice alone, isn't it? We always eat a mixed meal. We don't eat just boiled rice alone. So this red rice meal is just the boiled red rice, which has a high glycemic index and high glycemic load. But if it is combined with the other things we eat, like leaves, vegetables, proteins, fat, everything in combination we eat, then the glycemic index becomes low from high. And the glycemic load becomes medium, because the portion size also changes, as Nilesh mentioned. When we eat, it's not we have to always, when we eat some vegetables, actually a portion of the rice part goes down because we don't fill the plate with rice and then put the veggies, because we have to leave some space for the vegetables, meat, fish, whatever the protein source we have leaves. So we reduce some rice in order to accommodate our vegetables. Then that will reduce the glycemic load as well. So what about the string hoppers made of? WF stands for wheat flour and RF stands for rice flour. So what do you think is better? Both equally bad. Both wheat flour and the rice flour, when string hoppers are made out of, has a high glycemic index and high glycemic load. So that is the physical property which has mattered here. And there are another few things which I would like to draw your attention here. Not every food. So let's say pittu with wheat flour and rice flour. Both has high glycemic index and high glycemic load. What about roti? Roti surprisingly has a low glycemic index and low glycemic index even made with wheat flour or rice flour. Because the physical property here again, because it is not easily digestible. It's not easily, it combines with, anyway, when we make roti, unlike string hoppers, we add some coconut. Coconut has this special effect. It adds a lot of fiber, it adds proteins, it adds fat. So all these things reduces the glycemic index, because when combined with, as I at the very beginning I mentioned, the fat in your food, proteins in your food, fibers in your food, everything has an effect on your glycemic index. It lowers your glycemic index. So it is associated with low glycemic index. And what about the ambul banana and kolikuttu? So you always advise eat half ripened ambul banana. So what do you think? But both ambul banana and kolikuttu has equal glycemic index and load, which is low. In other words, all these diabetic patients and all your patients can have whatever the banana. I always advise them to have one, whatever the variety, because these are proven from the research. And these are some other data about the glycemic index and the glycemic load per serving. And why I took this is, one thing is that spirits has low glycemic index and low glycemic load. So wanted to show that. And more than that, will you see this whole milk and the milk with low fat? What about the glycemic index? In whole milk, the glycemic index is lower than the milk with low fat. Why is that again? Because of the fat, which has reduced the glycemic index, the absorption. So it's very interesting, isn't it? And the ice cream also has the same thing. The low fat ice cream has a high glycemic index, whereas the ice cream with normal fat has a low glycemic index. And per serving also it is the same. Therefore, we should not morbidly be scared of having an ice cream. If your patient is a diabetic, you can give them some freedom, because these things are not going to raise their blood sugar to 500 or above. So I think this is going to be the last slide. So this is about the kurakkam. So everybody fancies kurakkam. People think in fact, their diabetes will get cured if they eat kurakkam. But see, the glycemic index is moderate and almost like in kurakkam pittu has a moderate glycemic index. Kurakkam, roti, atta roti, all these things have a moderate glycemic index, and whereas the thosai has almost a high glycemic index, above 70, we call it high glycemic index. So these are the glycemic values for our commonly used food, Sri Lankan food. So ladies and gentlemen, so if you want to have an ice cream and if you are a diabetic, so what will you do? So just to provoke your thoughts, but there are a lot of things. I'm not promoting the diabetics patients to eat ice cream or for asking you to advise your patients to eat ice cream, but be a little liberal on your patients when you're prescribing diets, because we are there to make their lives less miserable. So that concludes my presentation. Thank you very much for listening.
Thank you, madam, for that excellent presentation. So everybody is waiting to have ice cream now.
Hopefully. So if there are any questions, I'm happy to take.
I have a small question. What about the product Acabose? You did
Yes,
mention.
alpha glucosidase inhibitor. That is alpha glucosidase inhibitor, which reduces the absorption of the glucose from the gut and has some effects on the liver also. It's a good drug, but I'm a little reluctant to start patients on acarbose because there are a lot of gastrointestinal adverse effects. It is a good drug, especially to reduce the postprandial glycemia. And it's a good drug when it comes to reactive hypoglycemia. I use it when there are patients with reactive hypoglycemia because that is well known to reduce the occurrence of reactive hypoglycemia. But because of the adverse effects on their gut, the use has been limited, but it's a good drug. Yes, no long-term detrimental effects. Non-diabetic and a diabetic with a good control. Regarding what? Yeah, non-diabetic. Prognosis. Fine, I understand your question. So you asked me what will happen to the lifespan of a diabetic. Yes, 7 to 10 year reduction of their lifespan. If they are not, if it's a diabetic, but if it is a well-controlled diabetic, probably 3 or 4 year reduction of their lifespan when compared with a non-diabetic. The lifespan still prognosis in the point of what? Yes, in the actually prognosis when we are talking about, we have to talk about either cardiovascular, renal, or the lifespan, mortality, morbidity, whatever with some point. So I take your question as the mortality and the lifespan. So as I told you, if it is a non-diabetic, with a diabetic, even if it is well controlled, still they will have about 3 to 4 year reduction of their lifespan. If it is poorly controlled, it may be really worse. Generally, if it is the control is poor, about 7 to 10 year years of reduction of their life is expected. Yes.
Was 120 or around about there.
Yes.
So HbA1c always came between 6 and 6.5. So I'm careful about taking very sweet things, but otherwise I don't control my diet very much. Well, I control in the sense that I avoid too much of carbohydrate and too much of sweet things. So is there any harm in having a HbA1c between 6 and 6.5 all the time?
Yes. So when the fasting blood sugar is between 100 to 126, when the postprandial is between 140 to 199, and when HbA1c is between 5.6 to 6.5, we call them pre-diabetics. So there are several studies to say that starting on treatment could be beneficial, especially in younger people and who do not have other complications. And in elderly people, that is above 70, we may monitor them without initiation of treatment. And there were studies to compare the lifestyle modification and metformin therapy for the pre-diabetics, because pre-diabetes is also associated with some risks of neuropathy and nephropathy. People can get some risk, or they can develop neuropathy even at the pre-diabetic state. That is the main reason why the people are thinking in the line of treating them. Therefore, in most of the other countries, and even the guidelines do recommend initiation of metformin to prevent them developing overt diabetes in the long run, especially for the younger people. So otherwise, if you can monitor yourself like every 3 to 6 months with the HbA1c, and as long as you are having your exercise and you are adhering to a healthy diet, then you can control with the diet, because most of these side effects do occur in the long run, like in about 5 to 10 years, when a person's expected lifespan is like, let's say in a 80-year-old person, or sometimes maybe 75, 80. we may not gain anything by controlling their sugar to a non-diabetic range, because by the time they develop microvascular complications like neuropathy or nephropathy, their normal lifespan is gone. So for a young person, or else even the elderly people, like you might have seen that guidelines which was published in 2016 by ADA. There are several factors we consider when we are initiating a treatment. Life is not a barrier. If the person is very motivated, even irrespective of the age, if they do not have any complications developed so far and has a good family support and has a, especially if they are morally really motivated, controlling their HbA1c to less than 6.5, that is for over diabetic, is recommended. So life is no barrier, definitely. If you are very happy to have a very good control, and because sometimes suddenly with these pre-diabetics, let's say with the infection, especially with COVID-19, we have seen a lot of pre-diabetics and the non-diabetics develop diabetes. Actually, that is, there are some theories and a lot of papers came up recently. The COVID-19, the virus attacks the pancreatic ACE2 receptors. Pancreatic ACE2 receptors are, because that COVID virus binds the ACE2 receptor, and when they bind the ACE2 receptors in the pancreatic beta cells gets destroyed. Then they have developed diabetes. So some of these people are the pre-diabetics. Therefore, during an intercurrent illness, an infection, something serious, some severe stress, they can cross the border. Therefore, we have it's the patient's preference and the doctor's preference. By discussing among both, you can make a decision whether to start or not on treatment, like in the entry HbA1c, like in less than 7.5. Therefore, you can start with monotherapy, the safest being metformin, provided there are no contraindications.
Thank you, madam, for that excellent presentation. On behalf of the IMPA, let me hand over this token of appreciation. Since we are running behind schedule, I would like to, our secretaries are not here, so I would like to make a vote of thanks to the two guest lecturers, one who's here, and thank you for excellent presentation. And it has been recorded, so it will be going on to our website, and anybody wants can listen to it. And thank you for additionally giving us more information on diabetes and how to manage, especially glycemic index and glycemic load. Thank you, madam. And I would like to thank to the sponsors of tonight's program about laboratories, Mrs. Amira, who's I can't see him. Yes, thank you very much. And also like to thank the OPA staff and the restaurant management for the preparations done tonight. And we had to have, as I mentioned, a limited audience because of the COVID situation. But I think more people will be listening to your lecture, hopefully. So now let me invite each and every one of you all for this fellowship and dinner. Thank you. Good night. Have a safe journey back.